my name is Grace Reese and I'm an 8th semester nursing student at Lincoln University, and today I will be demonstrating nasopharyngeal and tracheostomy sectioning along with providing trach care to my patient. I'm knocking and introducing myself. My name is Grace. I'll be your nurse today. Hand hygiene, client privacy, and verifying my client. Mr. Smith, I'm going to be suctioning the secretions out of your nose and tracheostomy today and then getting a clean bandage on there, okay? I want to establish a non-verbal form of communication in which Mr. Smith can let me know if he's feeling distress. In this case, I'll have him raise his right hand, and so I will know to stop the procedure at that point. He is in high Fowler's, hyperoxygenated, towel across his chest, and I will now perform an assessment to rationalize why Mr. Smith needs suctioning today. Adventitious breath sounds, gurgling, cyanosis, loss of consciousness, increased respiration rate or pattern, and a decreased oxygen saturation would be a few of the indicators of why Mr. Smith may need suctioning today. So ensuring that everything here is ready to go, I will turn my suction on to 80 to 100 or per hospital policy. I will don clean gloves, and what I want to do is I want to check that my suctioning is working by occluding the suctioning and ensuring that everything is working properly, and it is. So I will get rid of my gloves, perform hand hygiene, and I will first do my nasogastric suctioning. So I want to open my suctioning kit, which is sterile. And being very careful not to break sterility, I take my container for my saline and put that up right first. And then I take some saline and I'll lip it to ensure that the saline remains sterile, and put some in my container. Next, I will perform hand hygiene. And now I put on my sterile gloves. Actually, before I put on my sterile gloves, I'm going to remove the oxygen so I don't get my hand dirty early. Now hand hygiene again, since I just touched something. And opening my sterile gloves. Cuff rolled a little bit there. I would normally get a new pair of gloves, but for the sake of this video, I'm just going to proceed. Okay, so may have broken sterility there. Again, I'm just going to proceed for the sake of this video. Okay, now that I'm sterile, I take my suction catheter and I will wind it here. I need to measure, so I'm going to measure from the nose to the ear to the tip of the xiphoid process for my nasopharyngeal sectioning. At this point, I coil it around my dominant hand, which will remain sterile, and I will hook it up, breaking sterility on my non-dominant hand here, and occlude it with my thumb to ensure that it's working. Lubricate my catheter. I will have Mr. Smith's neck extended slightly, and I'm choosing to go in the right nair, not applying suctioning as I go in, going down to the depth that I measured, and then pulling back a little bit before I apply suctioning, and then intermittent suctioning, 10 to 15 seconds, pulling back, and then a quick rinse. Giving Mr. Smith some time to rest here, oxygenating him, encouraging him to cough and deep breathe if needed. May want to, at this point, to check his pulse, respirations, just to ensure he's still doing well. I do as many passes as needed, but I don't want to go for more than about 5 minutes. And when I'm done, I want to ensure his oxygen saturation is back up to a good rate. His breath sounds are easy and natural. He's essentially having no trouble breathing. And then after his oxygen is returned to a normal rate, I do want to return his oxygen to those pre-hyperoxygenation levels. Turn off the suctioning after everything's cleaned out. Make sure that the next person who's suctioning has equipment at the bedside ready to go. And I want to document how Mr. Smith tolerated the procedure, breath sounds before and after, why I suctioned, the amount, color, consistency, and odor of secretions, and the number of passes and the size and type of suction catheter that I used. Typically at this point, I would wrap the suction catheter up in my glove and discard it, perform hand hygiene, ensure client safety before leaving, but I am going to go straight into the tracheal, the suctioning, for the sake of the video. So I, again, want to perform hand hygiene, knock before entering, introduce myself, verify my client, ensure that they know what's going on today, provide client privacy, hyperoxygenate them, have them sitting in semi-fowlers with a towel, have my suctioning ready to go, respect sterile procedure when I get ready to suction, and perform a respiratory assessment to rationalize why I am suctioning him today. That could be visible secretions, gurgling or adventitious breath sounds, increased pulse rate, increased respiration rate or pattern, could be decreased oxygen saturation, loss of decreased consciousness, or cyanosis anywhere in the body would all be good reasons to suction Mr. Smith today. And I've removed the oxygen. Once he's hyperoxygenated, we have established he can raise his right hand if he's experiencing any respiratory distress. I have lubricated my suction catheter, and I enter using, after testing to make sure my suctioning works, I enter about 10 to 15 centimeters until my client coughs or until I meet resistance. And then I pull back 1 to 2 centimeters before applying suction to not damage the mucous membranes of the bifurcation. Rotating slightly, providing intermittent suction, about 10 seconds. And then suction some saline to clear this out. And then I want to assess Mr. Smith, allow 2 to 3 minutes between suctioning if I can, if he's not in respiratory distress. I could check his pulse, his respiration rate, look at him for signs of deoxygenating or respiratory distress. I could also give him some more oxygen now if needed. But I'm going back in, again, 10 to 15 centimeters, pulling back about 2 centimeters before I apply suctioning for about 10 seconds. So I can do this for a few passes, but I don't want to go for more than about 5 minutes total. And when I'm done, I clean out my tubing and I turn off my suctioning. Once Mr. Smith is oxygenated enough, I will turn his oxygen down to the pre-oxygenation levels and perform an assessment on him, see how he's doing, what his oxygen saturations and breath sounds are, how he tolerated the procedure. And then I want to document all of my assessments before and after, and then the amount, color, consistency, and odor of any secretions I got, along with how Mr. Smith tolerated the procedure. I want to make sure there's equipment for the next nurse at the bedside. Wrap this up in my glove and discard it. Perform hand hygiene. And clear my workspace for my next step, which is to perform hand hygiene, which is to provide trach care for Mr. Smith. At the bedside, when I'm providing trach care, I want to ensure that I have an obturator and inner cannula that is one size smaller in case Mr. Smith accidentally dislodges it. Again, I knock, introduce myself, perform hand hygiene, verify my patient, explain to him what's going on, ensure client privacy, make sure he's in semi-Fowlers, give him a towel, and hyperoxygenate him prior to the procedure. Once all that is done, I get ready to go. I, first of all, hopefully while I'm suctioning his trach, I've looked at the area. I want to know if it's bleeding, if there's secretions, if there's any swelling around the area, what the dressing looks like, and make sure that I document all of that. I also want to make sure he is hyperoxygenated prior to this as well. Once I have done all of this, I now perform hand hygiene and make sure I have my equipment at the bedside that is appropriate. We may also be wearing eye protection here. So I'm opening my tracheostomy care kit, and then I'm donning my sterile gloves. And I'm going to make sure my cuffs don't roll, don't break sterility here. My cuff is a little rolled there. Oh, I would not normally do this, but appears my gloves have been open. I just put it on the wrong hand. Apologies. So sorry, starting over. Picking up, donning my dominant hand, and then my non-dominant hand, making sure that my cuffs don't roll and I don't touch anything. If I did, normally I would start over, get a new pair of gloves, not touch my face or put my hands below my waist like I just did. So once I'm sterile and I have Mr. Smith ready to go, I take my little sterile field here, and I put that out, and I look at what I have in my sterile kit, and I have swabs, I have saline, I have hydrogen peroxide, I have a new bandage and some gauze here, and I have a new trach bandage. So first thing that I'm going to do is I'm going to put saline in 2 compartments, and in one of them I'm also going to put some hydrogen peroxide, half and half, and then I'll save some hydrogen peroxide if I need that for later. But in the third one, for my cleaning step that's last, I also want just plain saline. My first step is to remove the inner cannula, which I will do with by getting my non-dominant hand unsterile. So I pinch and twist the inner cannula. First, I drop it into the saline with hydrogen peroxide. Pick it up again with my non-dominant hand, with my clean sterile dominant hand. I will scrub, making sure my fingers don't touch to not ruin sterility. And then once I have scrubbed it with the saline and peroxide, I drop it into just plain saline to rinse. And at this point, it's considered sterile, so I do take it out and tap the saline out with my sterile hand before reinserting. My next step is to clean the area around the trach, and so I will remove the dressing, trying to stay as sterile as possible. So I am keeping this hand clean. I'm taking this dressing, I'm looking at it. Are there any secretions, crustiness, anything I should be documenting, anything to be concerned about? I then take my swabs, and one at a time, I would not want that to touch. One at a time. I dip them in saline. I could use some hydrogen peroxide as well if they're crusty secretions. And I clean around super well, cleaning, using each one once and then discarding, saline, discarding, maybe saline and peroxide. Here, cleaning, discarding, and then I will take some gauze in saline and clean around. And then I also want to take a dry gauze, and I want to dry this very thoroughly, make sure there's no moisture resting on the skin. And at this point I do break my sterility because I touch with both hands to get this dressing back on and up around here nice and securely. And normally I would want to have somebody maybe help me with this part because I would really want to avoid dislodging that trach. So we have a new bandage on there, a new gauze on there, and my last step is to put a new bandage around the trach. And so I'm going to wrap this around the back of Mr. Smith's head first, and I'll just do one side at a time. Again, I would normally want somebody to help me with this, but I will just undo one side at a time. And then undo the other side. And while I'm doing this, I'm assessing Mr. Smith. Maybe he needs to be oxygenated at this point. I want to make sure he's not having pain, he's not feeling a lot of pressure, anything like that. And I take this old bandage and I can just discard this, clean up my workstation here, discard my gloves, and then I want to document. I want to document what the original bandaging looked like, what the tracheostomy site looked like, how Mr. Smith tolerated the procedure, the type of catheter that was used, and then his respiration status before and after. And I believe when I am finished in this room, I want to make sure that Mr. Smith's bed is lowered. He has his side rails up, he has his call light within his hand, he doesn't need anything from me. And I believe that completes my video. Thank you.